This evening, an important topic, one that's I think we're going to hear a lot more of, particularly as we come out of the COVID epidemic, and we really have to learn the lessons of triage and separating out acute from scheduled care. And one of the ways of doing this is with the acute surgical assessment units, which have proven to be successful. Whoever has their microphone on and music in the background, maybe you might turn it off. Perfect. Thank you. I mean, one of the issues that we'll want to deal with is that there has to be a sufficient throughput in a 24-hour period to justify one of these, and whether or not all 26 hospitals across the country that have an open ED 24/7 would be appropriate for these. So this is the type of discussion that I would like to hear addressed. The answer may be yes. Or it may be that the volume of work is not there for that, and perhaps we need to rationalize it. And I'm just putting this out for discussion, that rationalization might follow along the lines of the trauma units that are to be established around the country. So something of the order of, and I'm not taking anything except the indicative number of 17 from the trauma report. So I think there's a robust discussion to be had, but we certainly do not want a situation where the acute surgical assessment units de facto become a minor injuries unit. What we really do need is senior decision making of significant acute surgical problems that warrant admission or warrant urgent review in an outpatient situation. So that's setting the scene for it. And I look forward very much to hearing from each of you this evening. And can I hand over now to Paul Ridgway, just to say to those participating, if you can put any questions that you have in the chat function, I will then put your questions to our speakers. We'll see how it goes. We may do it after each if there's a particularly appropriate question, pressing question for each of the presenters. If not, we might have a wide-ranging discussion towards the end. So, Paul, thank you very much again.
So, President, thank you very much indeed. And as our President has identified, this is going to be a warts and all presentation about ASAUs. During the Charter Day, we had some discussions around acute general surgery and ASAUs, so this is not just a repetition of this. So when we were deciding on the panel, Jamie said present and correct. We decided present was definitely needed, but correct was not. So we chose our first speaker very carefully. Professor Paul Balfe and I trained together, but Paul has managed to wiggle off the on-call rota a bit quicker than I, but not before he set up a very successful ASAU unit in Kilkenny in 2014, which subsequently became accredited by the National Accreditation Board for this, more of which Mr. Jamie Logan will talk about later. In between those two August dignitaries is Michelle Cook, and Michelle is a fantastic example about how to get stuff done on the ground. And Michelle has been involved in one of the earliest ASAUs in the country, that is the Limerick ASAU. So she's going to bring her knowledge and her learnings over that period of time. And I suppose to set the Q&A, because that's what really this is about, it'll be not just be about the presentations, it's more in fact about the Q&A afterwards. Is that what we want? Is we do want a robust discussion around what does the future look like? Remembering that ASAUs are there to provide senior decision makers to our patients, to allow effective care to be delivered first time for those acute surgical patients. The major utility And the major benefit of ASAU is actually decreasing the patient experience time. All the other benefits like an improvement in average length of stay, etc., fall out of pathways then that come out of seeing that patient a bit earlier in the day and being able to process that acute patient through theatre or ambulatory care as necessary. So without further ado, I'd like to hand over to Professor Paul Balfe for what I'm certainly looking forward to hearing.
Thanks, Ronan and Paul. I practiced this morning with Pauline, so let me get the slides up for you now. Can you see the slides?
Yes, Paul.
Okay. Can you see that slide, Paul?
If you go to the slideshow, perfect. Thanks.
Yeah, I have there. Okay. Thanks, Ronan. Okay, the topic, as Paul said there, the topic for discussion this evening follows on neatly from the parallel session we had at the Charter on emergency surgery. At the outset, let's consider 3 recurring scenarios that will be familiar to everyone and which to this day still define the status quo in the majority of hospitals throughout the country. And as we're always using the airline industry as an analogy to surgical practice, I thought I'd continue to do so here. In scenario 1, the patient presents to the emergency department, but the surgical team on call are unavailable because they are tied up with concomitant elective commitments, such as an elective theatre list, elective endoscopy list, OPD, procedure clinics, or whatever the case may be. The inevitable consequence is that there's a delay in senior surgical assessment, an increase in out-of-hours radiology, labs, and surgery, and there may even be, and often is, a clinical deterioration of the patient's condition. The corresponding aviation analogy would go something like this. We know your journey is urgent, but the captain and his or her crew are tied up flying another one of our aircraft and won't be available till later, maybe even much later. The second scenario is where the patient presents to the emergency department a number of times and is reviewed by an often unsupervised junior ED doctor, who perhaps through no fault of their own fails to appreciate that there's a surgical issue and inappropriately discharges the patient, who inevitably deteriorates, eventually representing, occasionally in extremis. Examples include RAF pain presenting eventually as perfed appendix, colorectal cancer diagnosed as simple constipation but eventually presenting with closed loop obstruction or indeed perforation, or a tender AAA diagnosed as renal ureteric colic, eventually presenting with rupture, all of which I have seen. This is a case of where the doctor's autonomy exceeds his or her competence and/or their experience. Again, the aviation analogy would go along the lines of one of our junior staff in another division of the airline, who's nevertheless done a few flying lessons, will be captain and co-pilot today. In scenario 3, the patient presents, is promptly worked up and put on an emergency list, then waits, sometimes greater than 24 hours, sometimes even more than 48 hours before his or her operation, because there's no designated emergency theatre and/or there are other competing specialties, for example, trauma and orthopedics, plastics, etc., ahead in the queue. Again, the patient's clinical condition may deteriorate while waiting, for example, progressing from a non-perforated to a perforated appendix. Now, the equivalent aviation analogy might go something like this. Well, sir, you're booked on this flight, and we would like, for your sake, to depart as soon as possible. But there are many flights waiting from many different airlines, and so all we can do is let you get on board and await a slot over the next, 12, 24, maybe even 48 hours. Now, no airline would operate on this basis, and neither should the health service. It's nearly a decade now since the publication of the NCPS Models of Care for Emergency and Elective Surgery, followed by more recent models for ASAU and the acute floor. In 2014, I and my three wonderful colleagues at St. Luke's, with no additional resources and no formal template, decided for once and for all to seek to implement the NCPS principle of separating acute and elective work streams by establishing an acute surgical assessment unit, while at all times remembering the wise words of President Woodrow Wilson: if you want to make enemies, try change something. And also recognizing that to have any chance of success, we would have to have buy-in from all relevant stakeholders and have prompt access to radiology and an emergency theatre. For our part, we defined an ASAU as a unit where patients who are deemed to have an acute surgical condition are managed directly by the surgical service at presentation. Underpinning such a model would involve a senior surgical decision maker early on in the patient pathway, prompt access to radiology and labs, and timely access to theatre. Now, the idea that a particular service should manage its own patients ab initio was not a new idea. Our medical colleagues embraced this concept almost 2 decades ago with the establishment of acute medical assessment units, and likewise our obs and gynae and pediatric colleagues. If anything, surgery was behind the curve. So at the beginning of 2014, having made the decision, we set ourselves the goal of a launch date of July of that year, thus giving ourselves 6 months to get everything in place. Bearing in mind that we would require buy-in from all the relevant hospital departments and stakeholders, we embarked on a comprehensive consultation process, meeting them all in turn. This was the most important and at the same time most time-consuming aspect of the project. It was essential to get widespread buy-in, especially from the departments I have highlighted in this slide. Key to the success of the venture was buy-in by our radiology colleagues, who agreed to set aside the first 2 CT slots each morning for ASAU patients admitted the night before, and all other requests throughout the day would be considered in consultation with the consultant radiologist on call. Surprisingly rarely, if ever, was there any dispute, partly because the discussion always involved an experienced surgical registrar or indeed the emergency consultant on duty. When we approached our colleagues, it was always with cases that everyone agreed should be accommodated. Ultrasound was always accommodated on the day requested. Equally important were the discussions with our anesthetic, obs and gynae, and theatre nursing colleagues. It was agreed that one of our 3 operating theatres would be designated as an emergency theatre for use by the general surgery and gynae teams. We drafted and agreed protocols, care pathways, process maps, etc. For example, the criteria for referral to the ASAU, which you see here. There are no surprises here, as they are all as you would expect. In the absence of additional resources, and necessity being the mother of invention, we negotiated with our ED colleagues to share the same physical space together with nursing and admin resources. This diagram shows the patient flow process into the ASAU. Patients presented either on foot of a GP letter or self-referred or were brought in by ambulance. They were triaged by the triage nurse on duty, and if the patient met the ASAU criteria as per the previous slide, they were referred directly into the ASAU. We developed new consultant work schedules such that at any one time, 3 of the 4 consultants would handle all the elective commitments, while the 4th would have emergency commitments only. The NCHD rotas also had to be revised to ensure that our NCHDs continued to gain experience across the breadth of general surgery. While we weren't DWTD compliant at the outset, and for that matter we weren't beforehand either, we eventually managed to recruit a small number of additional NCHDs on a cost-neutral basis, thus allowing us to become EWTD compliant with time. On the 14th of July 2014, we launched the first 24/7 365 ASAU. I have to say, though, that since the onset of COVID last year, this has now been reduced, understandably, to 12 hours because the resources had to be diverted elsewhere. What helped generate trust from the outset was the visible on-site consultant commitment to the project. The emergency surgeon became a very familiar presence on the acute floor every day of the week. Any staff member, day or night, could take up the phone and call the emergency surgeon on duty to discuss a case. Similarly with the GP community, who bought into the model hook, line and sinker from day one. On any day, any of them could call switch and ask to speak to the emergency consultant or reg on duty for that day. Although not without the odd issue here and there, usually about resource provision, the concept of an ASAU became embedded very quickly. Since its launch, we have conducted a number of audits, and it's amazing how the patterns of presentation, referral, etc. remain more or less the same. This chart shows the referral pathways, and not surprisingly, nearly 50% of referrals are from GPs, with around 40% being self-referrals. Nearly 70% of patients are seen within 1 hour of registration. Taking 2019 as the last normal, in inverted commas, year before COVID-19, there were 7,325 ASAU presentations, of which nearly 50% were admitted, which is consistent with both national and international ASAU KPIs, and around 45% discharged, most of whom would have had lab and or radiology investigations with follow-up arrangements, for example, OPD, endoscopy, etc. For me, this was one of the most welcome benefits, the significant reduction in out-of-hours emergency surgery Monday to Friday. Now, with prompt access to radiology and an emergency theatre, most of the emergency cases can be done during what is classed as normal working hours. As for the future, well, the ASAU model is here to stay. But in the future, it will form part of the integrated unit that is the acute floor model of care for all emergency presentations. This, however, shouldn't stop individual hospitals setting up ASAUs in the meantime, with the help and guidance of Paul Ridgway, Jamie Logan, and their colleagues in the NCPS office. As regards future staffing of such units, I would envisage a combined role for doctors, advanced nurse practitioners, and physician assistants. In conclusion, the NCPS models of care are now a decade old, but still as relevant as ever. For the patient's sake, and for the doctors too, the only sensible there is the separation of acute and elective work streams. Progress on this front has been very slow to date, and I can't help but discern a reluctance to embrace the concept. We were flying blind at the time, but now there's plenty of excellent support and guidance from Paul and Jamie in the NCPS. But if you take it on, do not underestimate the initial and ongoing commitment required by the surgical service collectively and individually. You will also need organizational buy-in. It's a tough proposition as it is. Would be, in my opinion, nigh impossible without the buy-in of your hospital management and your radiology, anesthetic, and ED colleagues. Finally, it needs to be properly resourced, which hasn't been the case to date. I hope the presentation has provided some food for thought for you all, and I would like once again to express my sincerest thanks for the invitation to present to you here this evening. Thank you.
Well, thank you very much indeed. And it's always a pleasure to hear the sort of the on the ground for someone who has delivered. What I might do is we might just hold the questions just to keep the flow of the meeting and invite Michelle Cook. So Ms. Cook is Assistant Director of Nursing in University Hospital Limerick and has supported one of the earliest ASAUs in the country for a good period of time now in delivering excellent care to her acute surgical patients. So Michelle, welcome and thank you for joining us tonight. If you'd like to load your slides. Maybe.
Yeah, I'm just having difficulty here, Paul. Can you hear me?
I can hear you fine, Michelle.
Hey, how are you? I'm just having difficulty loading the slides in this sense, so apologies. I can forward them on after the presentation. There's no problem. I'm happy to talk through.
Even
can
if you
you share your screen?
Yeah, there's just a difficulty uploading the slides onto my device, so I'll have to forward them on at a later date. Is that okay?
Sorry to interrupt. Does Pauline have your slides?
No, she doesn't have my slides. No.
Michelle, if you're happy to talk to it, we're more than happy to listen.
Perfect, Paul. Perfect. I suppose just to follow on there from the presentation, and thank you again for the opportunity for speaking here tonight, Paul. I suppose the last year has been quite challenging and has brought on new ventures here at University Hospital Limerick. And I suppose to open the presentation, the differences that we've come through in the last year have been quite tremendous in the sense of the volume and the numbers of patients that we've had through the unit. And to give you a bit of a background on it, as you mentioned, we were one of the first ASAUs in the country to set up, and we were primarily GP referrals through our emergency department since and over the number of years. With the new accreditation programme coming on in the national clinical programmes, we've migrated towards that model in terms of the emergency department and the direct primary care referrals as well in terms of surgical assessments. The differences that we've faced this year, I suppose, in March of 2020, our emergency department, in line with national guidance, I suppose, had to look at the COVID and the non-COVID pathway through our emergency department and our surgical assessment unit. While it originally was seeing general surgical presentations, we went within the space of a week to seeing every presentation that would present from a surgical perspective under all the subspecialties from urology, gynae, orthopedic, maxillofacial and general surgical. And we went from a Monday to Friday service to 24/7. And this was all supported through unscheduled care and through the hospital crisis management team, and pathways were drawn up to support the safe assessment of the non-COVID pathway for our patients through our hospital. And I suppose with that we had to bring in nursing resources, and we had to pull in the educational piece around these new presentations that would be presenting to the acute surgical assessment unit in line with urology, gynae and orthopedic. So we had a huge training piece to do with the nursing in the department, and I suppose we had the support and the fact that elective activity was stepped down during COVID. We had the NCHDs and consultants of the different subspecialties were more available from an unscheduled care perspective. So that did work well. They saw the senior decision maker earlier in the pathway in terms of the subspecialties, and I suppose that the challenges to theatre were reduced when our elective activities stepped down. Just in terms of figures and stuff that we would have seen, I was just looking at them there in comparison to March, April, May and June. We were up on 1,000 to 1,500 patients a month with all the different subspecialties, and I just looked at it there for December just gone, and we were down to 669. So what has changed from the first wave to the second wave and even the third wave of the recent pandemic is that the numbers have reduced, I suppose, in terms of the presentations to the emergency department in line with the COVID pathways. Like we were seeing a lot of polytraumas. They were all coming up towards the unit as well, but that has reverted back somewhat, and our emergency department has now got a clean zone as such. So we have where they can see the minor treatments like they had done previously, and the other 3 zones are dedicated to the COVID patients or the COVID suspect patients. So there is tight escalation protocols in place to ensure the safe pathway of patients when they come into our hospital, and that's what has been the difference in managing the volume of patients that we are managing through the hospital, in the sense that I suppose one of the challenges we found was that our assessment unit, while it was working out of 8 bays back in 2019. We went from 8 bays to 16, but our waiting area is quite small, and we were challenged in the sense of social distancing in line with national guidelines from a COVID perspective. So we had those challenges. We put escalation protocols in place, which were very beneficial, and we have a lot of safety pauses in place in terms of when we reach capacity and our patient flow from the other end. They were the organisational challenges, and we had huge buy-in from exec in terms of nursing WTE, in terms of NCHD support, and it was very everybody came together on that, and it worked really well. Absolutely, there was lessons learned, and I suppose that's something that we're going back, having focus groups now with our nursing department and along with our NCHD colleagues as well, to see what lessons were learned, what can we do what can we do if this reverted again, and coming out of the emergence of COVID, we will be guided by national guidelines on that, but we are in discussions early next week in terms from an unscheduled care perspective, what's the new normal going to look like, and that, I suppose, what we were back in 2019, when the principles of the senior decision maker will stay in place. The subspecialty piece in terms of the urology, the gynae, maxillofacial, all the other subspecialties, how can we sustain that going forward in terms of seeing the senior decision maker? And one of the key pieces that we found during the pandemic was we had redeployed our CNS colleagues and some of our A&P in the subspecialties, and definitely the A&P concept really works well. They're a senior decision maker, and that's something that we've put forward in a business case going forward, and it's something that from our nursing department are advocating on, to have the senior decision maker going forward in the unit. While during COVID, we had the elective activity was stepped down. We now are living in an era where the elective activity needs to progress with our waiting lists and our oncology department cancer patients. We need to support from a surgical perspective there. So the new normal now is looking at, I suppose, the NCHD piece isn't as readily available because of elective activity stepping up again. So we need to look at how can we sustain this going forward from an unscheduled care perspective. I like to pause analogy there about the aircraft piece. It definitely is about balancing act on that aircraft and how we can safely manage everybody on it in the new normal. The plans to revert will be new. I suppose it won't be like what we were in 2019, but keeping the KPIs is our aim in terms of the new surgical assessment unit in this new COVID emergence era. And those discussions are underway at the end of this week and beginning of next week as what that would look like, and what we need as an organisation to support the patient pathway safely during a COVID era, and what measures and what strategies we need to put in place to support that. And definitely the pathway piece in terms of the COVID, the non-COVID, the traffic light system through the triage is one way of supporting that and aligning whether your patient is on the COVID journey or the non-COVID journey, and then from there on, who they see above in our surgical assessment unit is the A&P the way to go, and in terms of what we have learned over the last year, it has been invaluable. So definitely the focus groups will definitely help that, and seeing what people's thoughts and concepts on that on the ground during the pandemic were invaluable. I suppose that's where the future for us here at University Hospital Limerick looks like. Will we maintain at the 16 bays? Will we continue with the subspecialties? I think that's the way forward, and absolutely the role of the A&P will be invaluable in keeping up with those KPIs, especially with reviewing that senior decision maker within the 30 minutes, and continuing our the 5 KPIs in line with the accreditation model would be our aim going forward, Paul. And that concludes my discussion for the evening, and I will send on the slides. Apologies on that.
Paul, you're mute.
Hello, oh yeah.
Paul, you're mute.
Yeah. Some people say that's the best way to have me. Michelle, thank you very much indeed. Your presentation was extremely clear, even without the slides. Thank you so much. It's good to hear not only what was happening in such a mature unit as you've had, and in fact, your new digs that you've moved into just recently, the 16 bays is fantastic. For those of you that have seen it, it's well worth a visit if you haven't. It's also interesting to hear what you think of that senior decision making going forward, and certainly I think that will be a hot topic of discussion in the Q&A at the end. So just to keep the flow going, I'd like to invite Mr. Jamie Logan, who's the nurse lead at the National Clinical Programmes, but he also is the chair of the Accreditation and Review Board of the ASAU project. This is a national project that we do between RCSI, the HSE, and in fact the HPO, so the Health Pricing Office, who attaches money to all of what we do in healthcare in Ireland, as well as the Acute Hospitals Division, which are represented on the board as well. So, so Jamie, please take it away.
Thanks, Paul. Thanks for the invite here to speak. I'm just going to share my screen. Hopefully you can see that now. So thanks for the invite, Paul. Mr. President, I'm Jamie Logan, the chair of the Accreditation Review Board and the nurse lead for the clinical programme in surgery. So I thought it might just be beneficial for those of you who aren't that familiar with an ASAU to talk about where we've come from. And as Paul Balfe alluded to there, of course, we're a decade on now from the original models of care in acute and elective surgery that was advocating for the separation of scheduled and unscheduled services. And out of this came a few years later the accreditation and minimum standards for an ASAU document, which many people have spoken about this evening already. So where did we start? We started with pilots in Dublin here in the Mater, a unit off the side of ED, and in Galway, a unit off the side of their ESU with some elective bed stock to test the concept and prove the concept of an ASAU nationwide. Following on from these, there were multiple sites nationwide, as we've heard from today, who've come on board with an ASAU and have been accredited. We know that there are other sites nationwide who haven't yet gained accreditation standards, and I'll talk about the accreditation piece a little bit later on, but we've now got units up in Our Lady of Lourdes up in Drogheda, the pilot sites in both Mater and Galway. Of course, we've heard from Paul and Michelle from Limerick and Kilkenny, and then we've also got a unit down in Cork University Hospital in the south. So this is how we did stand, and then of course 2020 happened, and there were significant changes to all service delivery, but also to ASAUs throughout the country. And we've heard of some of the changes there from Michelle, who's talked about, you know, the increased in beds and the additional criteria for coming into the units. But what happened in 2020 was the Mater closed for a period of time. Like many services nationwide, staff were redeployed as part of the pandemic response. And as we've heard from Michelle, that the ASAUs over in Galway and Limerick changed their banner. They changed from an ASAU into a surgical ED for a unscheduled surgical streamlined pathway into a senior decision maker, and both of those are still operating as a surgical ED at the moment. We've heard from Michelle that, you know, they increased in beds, and we'll be looking to transfer those back to an ASAU in due course when obviously, hopefully, the pandemic becomes a little bit more settled. Other services around the country, Our Lady of Lourdes, St Luke's, as we heard from Paul, and Cork, with minor changes, some changes of location, some different staffing, and some different bed stock, have continued business as usual throughout 2020. We've talked about KPIs, and for those people who aren't familiar with the KPIs that we collect as an ASAU, accredited units, when we go in to accredit them, report on 4 key KPIs, which is about seeing, reducing the patient's PET time and making sure that we see patients are seen within 4 hours. Paul's data there was fantastic from St Luke's. Clearly, they're achieving KPI 1. We look at the conversion rate into an admission, which is KPI 2. The first time to be seen in an ED, so that first senior decision maker at the front door, and there's been some talk already about senior decision makers and what they look like. And then the 4th KPI there is the triage category 5 from the ED perspective. And this is really making sure that we're just ensuring that we're not a quick stop to an outpatient. This category 5 patients should be get seen in outpatients. They're not urgent. They don't need to come through the ASAU. So we're trying to keep that below 10%, which all of the units are achieving with a robust admission criteria. And in terms of the accreditation, what happens, as Paul said, this is a collaborative piece between ourselves in the clinical program in surgery, between the acute operations in Vida Hamilton's office in the HSE, and between the health pricing office, where we visit a site. We have an accreditation standards document, which is the minimum standards document, and we accredit against this. There's 3 different outcomes. You can either get full, partial, or unaccredited. The majority of sites so far have got partial accreditation, where they need to achieve between 75 to 94% of the must standards. And at that point, we say, well done, you're doing a good job. We need to have an action plan in place for those standards that you're not quite meeting yet, and we'll come back and see you in a year's time. And the benefit of the accreditation is fairly clear. It standardises practice nationwide, makes sure that we have learnt from lessons from the acute medical units, where there's different models throughout the country. This really ensures that ASAUs are all singing off the same hymn sheet. But also, one of the other benefits of the accreditation is an accredited unit gets set up on HYPE as a ward area, and then we start collecting data. We start collecting really rich HYPE data for the accredited units, and along with that goes funding. The patients come out of the ED stream and go into a different funding stream. So there's some clear benefits there for the accreditation to encourage sites to go down the accreditation pathway. And this is just an example. We've got some data coming in from the HPO now, which isn't a full data set. Obviously, COVID has challenged us. We got to the start of 2020 with 6 accredited units, but obviously there's been 2 sites there that have dropped off the HYPE data and turning into surgical EDs. But you can see that the number of patients coming through there at the bottom there, 5,000 plus. This is in a 9-month period from 4 sites, and you would expect the 15 to 44 age group would be the highest attenders. And as Paul said earlier, it's the standard complaints that are coming through: the abdominal pains, your major and minor digestive, cellulitis, and your biliary tracts that are seen, treated, either discharged or admitted up house. So clearly the future's exciting by trying to get data now from HYPE, and we can really get some key metrics from sites going forward. So in terms of what's next, we would obviously hope to get the 2 sites that are currently working as surgical EDs back on to transferring back to an ASAU. The data that we've just shown there will become richer from HYPE, with the HPO there on board and bringing some really positive reports from what's going on with clinical sites there based on their own coding data. The standards document was originally published in 2017, and that's just coming up for an update now. And as we've heard today, there's been conversations around senior decision makers against staffing and KPIs, and all of those will be updated in the most recent standards document. The accreditation cycle, as with lots of things during COVID, has been paused. And again, as Michelle said, creating the new normal and getting the accreditation cycle back up and running is one of our priorities, and obviously bringing on additional sites as and when they're able. Obviously, there's sites out there that have had challenges with COVID that at present won't get through the accreditation status, so we're waiting to bring them on board and accredit additional sites as and when they come up. And as has already been discussed tonight, there are some challenges out there with the staffing. I know Paul was alluding to the NCHD exposure and ensuring that this is a positive learning experience for the NCHDs, as well as the on-call rota challenges. And there was some allusion there to physicians associates and nurses in an advanced role, all of which will be discussed going forward. As I say, the accreditation piece and COVID, travelling outside of our own county and into different hospitals, and the data collection, it's really interrupted our data flow with COVID, with obviously sites not collecting. So hopefully that will come on board again, and we'll have a full year of data from all 6 of our accredited sites nationwide. And just to end on a little bit of positive, we talk about how great ASAUs are, but here it is in pictures. In 2019, the patient experience survey that was carried out from all 6 sites nationwide, which, as you can see, clearly patients love an ASAU. They get seen quick, they understand the plan, they receive information, they're treated with dignity and respect, and really ASAUs, we're hopeful, will form part of the acute floor going forward and roll out to more patients to provide them with a positive experience. Thanks very much, Paul.
Jamie, thank you very much indeed. Now I invite all our speakers to unmute, please. So thank you indeed for those that have submitted your questions, and I'll try and group them together as best I can. I'm going to start with that point around the senior decision maker. I know there's a definition in the document, and I might start with you, Paul, if that's okay, around that a senior decision maker should be of a trainee of a standard that can admit and discharge. Yet we have heard discussions around what that person may look like going forward. So what are your thoughts on that senior decision maker role, a role that we know is difficult to staff on an ongoing basis, but on an intermittent basis can be done?
Well, I don't agree that it's difficult to staff. If you've separated out elective from emergency surgery, that means that there's always a team on call who are dedicated to nothing else. And a senior decision maker is the registrar on the team or the consultant. One of the reasons for success in our unit was that we were available. The ED nurse would ring me up if I was the surgeon on duty. 5 minutes later, I'd be there because that's what I was there for that day. Now, unless I was tied up in theatre or an emergency case from the night before or something, but then the registrar would go down or whatever. But there's always one of us there. That's the fundamental principle, separating out elective commitments from emergency commitments, such that senior decision makers, i.e. the registrar, senior registrar, or consultant, are available.
And in Kilkenny, you did have an adequately resourced ASAU in terms of providing that. But what happens, say, if you and the registrar are doing the surgery? Is there a second registrar, or is there someone who is dedicated in the role for the day?
Well, it's the same old story. If you're caught up with an emergency case that's so heavy that you can't spare the registrar to go down, then you can ask the SHO on that occasion to go down, do the assessment, and come back up to theatre, and then you can make a judgment as to whether or not you need to free the registrar to go down. But I have to be honest, it didn't occur that often. As you know our unit very well, we're a very collegiate bunch down there, and there'll always be someone else available. If it was the case that you were stuck and there was a patient in extremis down in that would always be covered. But I have to say that didn't occur that often. We had a very fluid collegiate situation down there, as you know. And so if I was tied up in theatre and with a heavy case and the registrar was with me, I would just say it to Rick or Faisal or Osama, would they cover for me for the hour or two that I would be up there, and that would sort it. That is on that point, that is a fundamental, I've often discussed it with you, Paul, it's a fundamental thing. You cannot launch this if you don't get on with your colleagues. You all have to buy into it together. There's no point in us not talking about this. If each of you are individual silos who don't work as a unit, it ain't going to work, because it does involve handover the next day of emergency cases to the new team coming on, etc. So you really got to get on with your colleagues, and all of you have to buy into it together.
Thanks. And Michelle, maybe coming to you, and I'm not in any way suggesting that Limerick isn't any way as collegial as Kilkenny, but in terms of your model, the registrar is there all the time, available to see everybody within the KPI, which is within 30 minutes of arrival. How do you see that evolving over time, as perhaps all our units are going to get busier and busier? Maybe what Professor Balfe was saying around the ability for the on-call service alone to be able to administer to ASU being available to you.
Yeah, I suppose it. We do have a registrar that's based in the unit. 12 hours per day, and then it's on call at night. I suppose it's the volume of patients that come in at one particular time to see one registrar. That's the challenging piece. And I suppose on a Model 4 hospital, there's quite a large volume that comes through our emergency department on a daily basis, and it's about putting the patient in the right place at the right time. So there is days where it is challenging to meet that KPI, and what we've noticed, I suppose, in dividing it into the subspecialties, not all the subspecialties will see the patient within the 30 minutes, so that's proving challenging. And I suppose the A&P model could be an answer to that in terms of assessing the patient and seeing them directly when they arrive into the unit, and then dividing out into the subspecialty if the registrar is so they work in align with the registrar. So that's probably one solution maybe going forward. It is to see all the subspecialties. I think that's the challenge, and the sheer volume. Like, for instance, there only yesterday within 1 hour 8 patients arrived up into the department, so you're not going to see all 8 patients within 30 minutes. So that's the kind of reality in terms of numbers, and that's what we're seeing. It fluctuates up and down. So I'd just be interested to hear how in St. Luke's, maybe how you manage that in terms of the volume, but maybe the volume isn't an issue. I'm not familiar.
Okay, I might go to Jamie next. Jamie, you've seen then all manner of shapes and sizes of the ASAUs in Ireland. And maybe what's your view on that point? There is a little bit of variance over what that senior decision maker is and does on each site.
Yeah, absolutely, Paul. I mean, from the units that we've visited throughout the country, there is multiple different sizes that fits all for a senior decision maker. What we do know is the definition of a senior decision maker currently stands at a surgical professional of at least ST3 grade or equivalent, and that equivalent allows for, as Michelle said, the A&P piece, as Paul was alluding to, potentially the physician's associate piece, but we do know that the ASAU is in a prime location to have that senior decision maker, whatever the professional looks like, as close to the front door to get that surgical decision as early in the patient's journey as possible. And as you've seen with the KPI, that's measured with that KPI, and then precludes the up-house admissions or gets them admitted up-house much quicker.
Okay, and I suppose our emergency medicine colleagues are before us in this, in that they already have those advanced nursing roles in for rapid assessment, and that is probably what we're talking about at the moment. And how we can input that model while not devaluing surgical training for our both subspecialty and specialty trainees going forward. Moving on, there has been some questions around what models of on-call looks like. And I might come to you, Paul Balfe. So we know there's 3 basic models in Ireland, which is the super elective, which means you just carry on as normal and do your elective work. The reduced elective, which in some way your elective work is curtailed but not to zero, and then the surgeon of the week model, which mightn't be a week but might be a block of time. So the question was around, well, how do you do it in Kilkenny, and why isn't everybody doing it?
Well, there are many ways to skin, and I wouldn't like to be too prescriptive about it. The bottom line is that whether or not you're on call 1 day, 2 days, or a week at a time, it really doesn't make any difference, as long as that fundamental principle that the person on duty should be free at all times. I don't buy into this thing of having reduced commitments, because you just know how that goes. It starts off, well, I'll have 3 on the scope list, then there's 2 added from that, and then it's 5, and then you have a full day, and you're back to square one. You're either going to do this right, or you're not going to do it at all. And let's face it, our emergency patients, as we discussed at the charter, haven't been well served by the models up to now, and they're still not being well served. And as you pointed out the other day on the phone to me, we're talking about a group of patients in whom there is the highest level of morbidity and mortality. So we have to get better at this. And no, I would say, I see a question there from Tim in Sligo. I mean, there's only one way to do it, and that is to free up the on-call team completely from all elective commitments on the day or days that they are on duty.
Yeah, and certainly in the programs we would ascribe to that, providing that the elective stream is sufficiently resourced on that day to cover off the other issue that we face, which is our expanding waiting lists. I might move off the models and on then to another question around Rick Praetorius, who runs the Kilkenny ASAU now, around how does the ASAU model fit into ambulatory care? So it is an assessment unit. It does and should discharge a number of the patients that it sees to the outside and ambulatory pathways. Jamie, I might go with you first and say, how do you see ASAUs then fitting into that going forward?
Yeah, like you say, Paul, the ASAU is currently populated from triage categories 3 and 4. So it's it's not your resource patients, it's your ambulatory patients already, and by definition, those who are walking into the ASAU who get seen, get discharged, and sent on their way with appropriate follow-up. We're kind of already there with the ambulatory care model, or we're certainly starting there. In terms of the ambulatory surgery day case coming in through the ASAU, then that's a space that we'll need to look into going forward into the future.
Okay, thank you, Jamie. Michelle, I might come to you then just about the next thing, which is COVID. So you talked about the effects that COVID has, and it's interesting. Every ASAU throughout the land was affected. Initially in the wave 1, probably positively, because we had a reduced elective commitment, and like Paul Balk was saying, that freed up a lot of time, and we saw patients actually made it through the system quicker. And in the data that we have from wave 1, the data from waves 2 and 3 is not mature yet, but we saw that although there was that third drop off in acute work, there was a decrease in the average length of stay associated with that work for whatever reason, be it more efficiency or other. The second and third waves, though, in COVID really negatively affected ASAUs in general. Was that your experience in Limerick? And how do we get back to where we were, as in a fully functioning unit, getting your 16 bays open and so on?
Yeah, I suppose, as we said, the first wave we saw huge numbers and we were all new to it as well. And I suppose a lot of lessons were learned from the first wave and subsequently into the second and third wave. I suppose the flexibility as the elective piece started to evolve, we didn't have as much on-call facilities to the unit in terms of the subspecialties as well. So it definitely had a strain. I suppose it was the length of time that the COVID lasted did have a strain on the service, and trying to maintain that going forward. There needs to be a huge input in terms from the diagnostic.
Sorry, Michelle, I think you've put yourself on mute.
Apologies.
Okay.
So I suppose to answer your question, Paul, yes, the first wave we saw huge numbers and huge volumes, and like everyone in the country, we learned as we went along with that, and we provide the safe care, and we had the Ireland's call, and we had all that piece that the whole nation came together, and we did have a lot of nurses and doctors alike that came home to provide service, and there was more free time from the elective piece being stepped down, and as we're progressing through this new wave, the second and the third wave, what we saw, I suppose, in the second and third wave was it did hit staffing. Staffing was a huge issue during the second and third. It's more or less the third wave as well in terms of the amount of staff and trying to manage the staff out on COVID leave across the whole hospital really was very challenging, and that was evident in the third wave. That wasn't so much there in the first wave, and then at the same time in the third wave you're trying to bring the elective model back in safely, as well as dealing with the emergency side of the fence as well. So it was really is a balancing act. I suppose we have more space created in the emergency department. Now, we had the whole block of the emergency department was the COVID pathway during the first wave. This wave now is post the third wave. We have stepped down one of the zones in the emergency department to create more capacity there for so there's a clean zone in a non-COVID zone in the emergency departments. That's up and running again. Again, is I suppose the numbers, as I mentioned there in June, we were seeing up on 1,000 to 1,500 patients. The numbers have dropped to, like, as I looked at there, December was up on 600 for the month. I suppose the patients that we're seeing coming in are quite they're sicker. They did spend a lot more time at home, and has that had an effect? And I suppose waiting on the data and the research from that will guide us on that. It's just I suppose to sustain it going forward and to keep the 24/7 model, is that something that can be sustained with the on-call piece and the subspecialty piece along with the nursing? There's a lot to consider, and I do think that the general surgical branching into the subspecialty of urology and gynae does work well. Patients are seen quicker and are seen in an area that's not a vast, huge emergency department area. It's a smaller area in our ASAU, having the 16 bays. So there is a lot of benefits from a patient's perspective in the unit in terms of that. It's just trying to sustain it, Paul, will be the challenge.
And your point around the data, Michelle, is probably key. So good data, what this is all based on. And I suppose on that point, there was a question from Tom Walsh about, can we rely on data? So just what we do is we have, for our accredited units, they do get HYPE coding, which is technically inpatient coding, but it's just an anomaly in the system, which AMAUs use to get some good data around that while we wait for all the hospitals to have acute floor information systems. Jamie, I know you're on that board for the acute floor information systems. Can you give us an update on when we can expect rollout of those systems, so those codes which allow us to code these emergency patients, which are different to inpatients because they don't always have diagnoses attached to them. They have symptoms rather than diagnoses. What's the status on that? Are we going to get better data for our ASAUs going forward with these?
Absolutely. I think you're totally right, Paul. As I alluded to, one of the benefits of the accredited units is the coding of the HYPE data, but of course that's just coding from a hospital site, which is now feeding through. And back to the point about the acute floor information system, which is the technology supporting the acute floor, which the acute surgical assessment unit will be part of, was planned to roll out pilot sites 1 and 2, which I believe from memory were St Luke's and Cork. That was planned to happen Q1 this year. Obviously with COVID, there's been some delays on that. I think it has gone out to procurement, and that will be probably later on this year. I'm led to believe Q4 2021 that we'll start seeing some pilots there.
Thank you. I'm conscious of the time. I do want to ask one very important question, just of Paul Balfe, just to briefly answer before I ask our president just to round up this evening's webinar. Paul, just training has been brought up a lot, and how do we train for emergency general surgery and ASAUs on that basis? It's going to be a significant challenge, and as Simon Cross asked, I mean, what are the rotas that we have? Well, we know from the ASAUs, the accredited centres, they range from a 1 in 4, 1 in 5, right up to a 1 in 15. So there is terrible heterogeneity, if you like, in what that on-call service looks like. So can we train? Can we have like a Cork model where we have emergency surgeons? What is the future? Perhaps we'll end on that.
Okay. Well, this is a point I laboured, I think, a bit at the charter meeting when talking about the new ISCP curriculum. The new ISCP curriculum for higher surgical trainees becomes operational in July of this year. Everybody recognises that there's a problem at the moment where the special interest has, the pursuit of a special interest, which we all have to do, of course, but has eroded into core emergency and elective competencies across the breadth of general surgery. And so much so that the ISCP decided to address the problem by producing a new curriculum that becomes effective from this year. And I think if we embrace that curriculum, we won't go far wrong. It's just untenable that you should come off the scheme. As one of the ST7 said to me there recently, he said, not only have I never taken out a spleen, I have never seen one done. And I have never repaired a vessel in my entire life. So, you know, contrast that with somebody like myself who gets a call because our gynae colleagues have put a trocar straight into the common iliac and I have to go up and fix it. Well, so be it, and fix it I do and continue to do, or did so up to the time I retired there in December. We have to ensure that people have, coming off the scheme, have the breadth of capabilities and competencies in general surgery. You know, let's say the past revisited again, and I'm absolutely convinced that if we embrace the ISCP curriculum, that will be the answer to your question.
Okay. Thank you, Paul. Obviously, some more work then to be done. On your behalf, I want to thank all our speakers. I apologise to the couple of questions I didn't get to. Morgan talked about the UK models, and Obina raised questions about two teams, one for ASAU and one for in hospitals. But perhaps we'll have to hold that off for another day because we are out of time. I'd like to hand back to our president, but on your behalf, thank all the speakers and indeed the audience for their engaged conversations tonight. Ronan, I think you're muted.
Ronan, you're mute.
I think we might be having some technical difficulties. Ronan, are you able to get off? No. So with your permission then, Ronan, what I'll do on your behalf is thank you very much indeed to all the speakers and all who attended tonight. It was very informative. I've certainly learned a good bit. I think ASAUs are here to stay. I think there's a significant body of work still to be done in finessing the model, but also finessing the on-call services across the country. And I think the RCSI and indeed the HSE are going to enter into some discussions over what that looks like. We have a couple of clear and present issues around delivering acute, particularly general surgical on call up and down the land. And I think really it's going to be a hot topic of conversation once this current COVID pandemic passes in coming months and the year ahead. So once again, thank you all for dialing in, and I wish you all the best.
And thank you very much, Paul.
Thanks, Paul. Bye now.
Thank you.